Good morning, everyone. My name is Dr. SUPRIYA Ganesh, and today our case is PHACO with ICL SITU in a case of high hyperopia. So phakic IOLs are a popular correction for high refractive errors in high myopia, hyperopia, where corneal procedures are unsuitable. A known complication following hyperopic ICL implantation is anterior subcapsular cataract. High refractive error, intraoperative trauma, inadequate vault, and advancing age contribute to this. In these cases, cataract extraction along with removal of ICL and implantation of PCIOL is usually performed. And among the third and fourth generation formulae, Haigis and Barrett Universal 2 showed better post-operative refractive results. So in our case, we present a 29-year-old male who underwent with counting finger 2-meter both eyes and corrected distance visual acuity of 20/40 with plus 13 in both eyes, underwent uneventful ICL implantation of 21 diopters in both eyes. His post-op uncorrected vision was 20/120 and corrected distance visual acuity is 20/40, and there was a residual refraction in both eyes of +4 and +4.5. 1 year after the surgery, he developed anterior subcapsular cataract in the left eye, and biometry using IOL Master 500 was done with a net IOL power of 47 diopters. At this point, the patient was not affordable, and there was no described method for calculating IOL power to be implanted while maintaining the ICL in situ. So a standard IOL of 22 diopters was placed, and a residual refraction of +3 diopters was there in the left eye. Now, 8 years after this, anterior subcapsular cataract was seen in the right eye also, and at this point we had the IOL Master 700 with Barrett Universal 2 formula with a net IOL power of +45 diopters. So a new method of IOL power calculation was devised. Basically, the initial refractive error was 13 diopters and the residual refractive error was +4. So the ICL has basically corrected only +9 diopters. Therefore, the target refraction should be +9. We kept to aim for a myopic astigmatism. We kept it as +9.5 and implanted this lens. This was the surgical technique where basically the two haptics of the ICL were tucked out and placed over the iris. The capsulotomy and the phaco aspiration IOL implantation was done under the ICL, and the haptics of the ICL were tucked back under the iris. This is the same biometry that I explained earlier, and the resulting IOL power that we got, keeping a target refraction of +9.5 diopters, was 30 diopters. So the 30 diopter lens was implanted instead of the 45 diopter lens. So you can see this is some of the patient information. Just note that the IOL power used in the right eye was 22 and in the left eye was 30, and the post-cataract surgery refraction in the left eye was just -0.75 cylinder compared to the right eye, which was +3. So just to discuss, the other methods that we could have used was to explant the IOL with cataract extraction, followed by implantation of a high-power custom IOL. This is more expensive, takes a special injector and a larger incision for a thicker lens. We could have explanted the ICL, followed by implantation of two IOLs, a primary piggyback, but complications like interlenticular opacification, PCO, glaucoma are there. So this innovative technique was used. The advantages are that it's cost effective, it reduces endothelial damage because the ICL acts as a shield, and a unique biometric formula resulting in negligible residual refractive error. The drawbacks were that it's more surgically challenging and potential complications are damage to the ICL, zonular damage, and difficult in harder cataracts. Thank you very much.
Thank you for your presentation, but I still feel that it was a better option that you could have explanted the ICL and then put the intraocular lens, because it was, of course, difficult procedure, cannot be done by every surgeon. Expert people will be able to do it, and then there are chances of endothelial cell damage.
Yes, so that's one of the drawbacks, but this particular patient wasn't affordable for a customized high-power IOL. So he initially, which is why this was almost performed 15 years ago, the first procedure, followed by 8 years after that procedure, where the customized high-powered IOLs were still very expensive at that point, and this particular patient was not affordable for that. So that's why this unique method was devised, and the surgery was uneventful and gave the patient in the left eye almost emmetropic vision, with the right eye had a +3 residue, but that was the reason why the new biometry was developed.
Just a point, no, this ICL is usually calculated based on the anterior chamber depth also,
Yes, sir.
because post-op the anterior chamber depth is going to change a lot.
Yeah.
Because it's gonna
Preoperatively, the anterior chamber depth was
was it considered in your formula which you said?
basically, sir, the formula was to see how much the ICL was already correcting. This wasn't a dense cataract. There was not any nuclear sclerosis. It was an anterior subcapsular cataract.
Basically, it will be not predictable in all
Yes,
the cases.
yes, sir. In this particular case, it worked. But normally with harder cataracts, that's one of the drawbacks that we can't predict it with this formula.
Yeah, I also feel that I agree with him, because as it is, it's a very hyperopic eye, and the space in the anterior chamber is very less. And then you have also exteriorized the haptics of the phakic lens.
In this
So as
particular-
such, there are too many things there which is in a very small AC, where I feel that it could have been a better option to explant the ICL. Maybe in very expert hands it's still possible, where without exteriorizing you can just probably do a phaco by, if the space is good. But otherwise I think it's probably prone to more complications.
In this particular patient, the anterior chamber depth was 3.5, sir, both eyes. So there was enough space, and viscoat was used. And also in denser cataracts, another option could be to explant the ICL, do the cataract surgery, and implant the same ICL using this formula. If it's not a dense cataract, if it's just an anterior subcapsular cataract because of the ICL, that could be a good option.
Which company's IOL was implanted in this, just to know?
IOL was Technis, the Johnson &
Did you
Johnson.
check Indian companies whether they'll make a 45 IOL, power IOL, which will be very, very cheap? If the expense is the cost is the
Yes,
main issue which you
yes,
have told.
Yes, sir.
Could you check it out?
Yes, sir. At that point, all the companies were tried, and it was properly evaluated and seen that the patient was not able to afford that lens. So,
This IOL was given free of cost to the patient?
sir,
This IOL was given free of cost to the patient?
it was not done free of cost, but it was done at a much lower
but
package.
because the patient was not able to afford the cost, and
Yes, sir.
I think Technis is not very cheap IOL, and there's I think
Yes, sir. It was
Orolab,
done at a lower
Appa,
package.
etc., are available.
Since we were able to implant the IOL of a standard power in the first eye, we did it at a much lower package. It was a sample lens that was used also. So it was a lower package that was done. Yes.
Thank you.